mast, and they send up the lookout to the top of the mast. Did they send up old men like me? No. Did they send up the best people, 25 to 30 years of age, who had a lot of experience? No. They sent up boys between the ages of 14 and 16, maybe 17. Why? Because they had a thicker lipid layer and their vision didn't blur. So if you go back to everything we know and you start to think about it, all of a sudden it makes sense. So anthropologically, from an anthropological point of view, we are not designed to do what we do. And we are going to have to address that. And the fact that public health is going to address this and not eye care is a tragedy, a complete tragedy. And the fact that we have resisted it, and the fact that we've been wearing the shackles of intellectual bondage, terrible. Just awful. And as we think back and we think of what we do, I mean, I think back for 28 years I looked at something and never registered. And when I went to a meeting and I would speak, half the people would walk out. When I gave my first lecture on this, I got the lowest rating in the history of the American Academy of Optometry. And before I gave this lecture, I always was the highest speaker at the Academy because people didn't want to hear it, they didn't understand it. So what we have to do, going back to the glaucoma, is when we see healthy, we see you in a couple of years. When we go ahead and we start to see dropout, bingo. We have to prevent that from happening, just like you prevent glaucoma from blinding people. How do we treat MGD? In 2016, we remove the obstruction and we treat the sequelae. So for home therapy, again, thermal, warm, wet compresses are the best. And the data is there. We have several publications on it, and there'll be 2 or 3 more publications. It's so important, coming out to explain all of the differences in warm compresses and how you do them. Now, there's a blephasteem. You're all familiar with the blephasteem in the country, which is why I put it in. It's a wonderful instrument, okay? And what it does is it gets the temperature up from 35 to about 38, 38 and a half. Is it as good as warm compresses? If the warm compresses are done perfectly, no. But people can put it on, people can wear it. So if people don't want to use warm compresses, they're a lot better off doing blephasteem for 12 or 15 minutes than they are not at all. So again, sometimes we can't get it all, we can't have perfection, but we still have to be doing something. And then there's other compresses. The compresses you heat in a microwave that are dry are way, way down. And some of them barely raise it 1 degree on the back of the lid. So they don't come close to 40 degrees, which is just about where the therapeutic temperature starts. So what we recommend, if people want to use that, is they put a wet towel over it. And that microwavable beads or whatever they happen to be inside helps keep the warm towel warm for a longer period of time. But clearly, the warm compress technique that I explained, the wrapping of the towels, has no peer. It's just clearly the best by all the data. And then in the office procedures, you can express them cold. Can optometrists in Spain manually express? You can manually express glands, yeah. So everybody should start manually expressing. But don't use too much force. It's better to express and keep the patient and have them come back and be half as effective as it is to turn their lids black and blue and they say, mañana, goodbye. I don't know, does that mean goodbye? No, but you understand me anyway. So office expression. Then there's a procedure of debridement, which I developed. And you take a golf ball spud, and if you can stain it with lissamine green, that's better, because then you're taking off the dead cells. And what happens is the liner marks, the mucocutaneous junction, develops all this material, and that impacts our blinking, because our blink our blinks don't touch like that. We all think the blinks touch like the door, like the sliding door touches the wall. No, it doesn't do that at all. The upper lid slides over the top lid. And if the lid margin isn't clean, the whole procedure of moving the material that the meibomian glands secrete in front onto the margin of the lid, that whole process is blocked by a high wall at the mucocutaneous junction of dead cells. So that's another whole lecture in itself. But just do the lid scrubs right over the orifices. That isn't over the orifices. But if they can scrub right over there, that's a big help. And then there's various methods. There's intense pulse light. There's probing where Steve Maskin in the United States developed a needle and you ram it down the meibomian glands. And it's interesting because there's no guarantee you're not putting it through the wall. And if you push hard, you frequently will get blood, which means that that's what you're doing. But a lot of people do it, and in some cases it's helpful. There's a technique which I invented, lipoflow. Then there's a technique in the United States, Meiboflow, which does not raise the temperature. And then there's some people use BlephX is a new procedure where there's a little rotary pad which turns at about 3,000 RPMs, and there's a cleaning agent. And the patient comes into the doctor, and it's a private pay procedure, which makes it very popular because the doctors don't get paid very much. So if they can do something and charge the patient, they're more prone to do it. And they use this BlephX machine, and it cleans the lids very well. It really helps getting rid of the seborrheic blepharitis. Now, as an aside, what Tony explained was just so important with the rapid turnover of cells. The lightly complected, blue-eyed person whose skin would burn in the sun. And there's a Fitzpatrick scale that we use. It's very old. It was developed. You hear of the Fitzpatrick scale, and it just says 1, 2, 3, 4, 5, and it defines it by how the skin looks and how it reacts in the sun. It was done by a dermatologist, and it works remarkably well, and it's very, very simple. But type 1 are blue-eyed, lightly complected, blondish, reddish people. And they are prone to seborrheic blepharitis. And for those of you, how many individuals, let's define what seborrheic blepharitis is. Seborrheic blepharitis is when there's a lot of material on the lid margins, which extends onto the eyelashes. It forms collarettes frequently around the lashes, and there's all this scurf and dead cells all over the place, as Tony showed. So if we think about that, how many of you doctors have ever seen that on individuals who you would say have black skin? Not very common. Not very common. You really got to think about it. So if you go back in and you look at dry eye practitioners in the United States, they're all light-skinned. 3 out of 4 of all my dry eye patients have blue eyes and light skin because they're much more prone to this, plus the fact their glands are not as big. And their glands aren't as big because they were designed to live in a cold climate. And the cold climate has less evaporation. So if you live in a warm climate, and for instance, black people, anthropologically, I'm told by the chairman at Berkeley, or I was told, that they were originally designed to grow up in deserts, not in the jungle, but in deserts. So if you look at their skin shines. So if you go around the room and you look at individuals, the darker the complexion, as we go from Fitzpatrick 1 to Fitzpatrick 2 to Fitzpatrick 3, you'll notice a shine coming off of the skin. And with many black people, they look just like mirrors. You can almost see your face in their skin. And they have beautiful skin because they have great oil. And they have great sebaceous glands. And And the Meibomian glands are only modified sebaceous glands. So that's the way it goes. And then, again, we've talked about this, so I won't talk about it again, except to say that there's a lot of other techniques like autologous serum, which are used for the very severe patients. But it's not the first step you take. It's a second stage, third stage, wherever you want to place it along the way you stage the complexity of treatments. So again, if we want to restore function, what we want to do is we want to raise the temperature on the inner surface so the Meibomian glands will be done. So here I'm looking at this for 30 years. And I have spent at least 30 hours a week on Meibomian glands for 30 years. And I looked at this. And I never figured out that we want to put the heat on the inside of the lid. So one day, we set up the experiments and we placed the heat on the inside of the lid. We placed the heat on the inside of the lid with a special probe where we could turn up the temperature while we were watching under a biomicroscope so we could be sure that we weren't doing any damage. And it's remarkable. You can heat the inside of the lid up to a temperature of about 43.5, 44, with just a topical, and there's no recurrent damage. There is evidence to say that you start heating above 46 and 47, you cause platelet damage. So I wouldn't advise anyone to think that more is better. And as a result of that, an instrument was developed called LipiFlow. And what LipiFlow does is it applies heat to both of the inner surfaces of the upper and lower lid while it's applying pressure. So maybe I have a better slide of that. Yeah. So what happens is that that's how it looks in the eye. We do both eyes at the same time. And yeah, here's your eyelid, there's your Meibomian glands, and there's the device. The device is put in, and the device sandwiches the lid between the inside, the anterior surface of which heats the lid, and the outside, which is a bladder, which applies constant pressure of between 2 and 6 pounds per square inch, which feels like massage. And it insulates the cornea so you don't do any damage to the cornea. Now, I should mention, by the way, that that many people, when they do warm compresses, tell the patient after the warm compress to rub, to massage heavily. And that's a big mistake because you change the corneal curvature. And with many individuals, you can start the process of a different type of keratoconus, where you get corneal irregularity and you develop real problems. But the astigmatism is always minus axis 180 with the rule, where with keratoconus it starts at minus axis 90 and then it goes oblique. So it's a little bit different, but you can cause permanent visual damage by massaging when the cornea has been heated. And when you heat with the warm compress, there's no protection, so you will raise the corneal temperature to exactly the same as the back surface of the lid. So if we put on a warm compress and we raise the temperature to 40 C at the back, we're raising the corneal temperature also to 40 C. And in the studies that were done, what happens is in the FDA trial, which was 278 individuals at 8 sites, we improved the gland function almost 3 times. And the symptoms were cut in half. In a 12-month duration study, which was done at 9 sites, the data is essentially the same. In a big study, not as large a study, with 62 patients, that was done before cataract surgery. And what happens is the first readings are the baseline readings, and then the second are after treatment. So what happened is after treatment of individuals before cataract surgery, and then they were treated, there were more Meibomian glands functioning and working. And the same thing with contact lens wearers. And treating somebody with LipiFlow and getting the meibomian glands open actually added almost 4 hours to their wearing time. So if we were going to have an algorithm, a method, a protocol for treating dry eye, we have to consider meibomian glands first, and we have to consider that the new word that I was taught by a colleague is foundational. It's the foundation, it's the basis for it all. And then there's many additional primary factors, including lid seal, partial blinking, and lid margins. Lid seal is when the lid's closed, and when you look at them, you're absolutely positive they're closed, but they're not sealed. They let air in. So all night long, the patient is effectively suffering from nocturnal lag ophthalmos, but the lids are shut, and the air comes in. And that's why many times we see in the morning, we see the staining in the morning, or we have symptoms, and many patients will tell you, my eyes bother me most in the morning. Well, why should they bother them most in the morning? They should feel the best in the morning. But the reason is the lids aren't sealed. And, after meibomian gland treatment, we should treat them as we see fit. So in addition to meibomian gland treatment, you want to try to increase aqueous secretion with Restasis, fine. You may want to use steroids to get the eye quieter more quickly, fine. If you think the person needs antibiotics because of blepharitis or something else, fine. So whatever you want to do, it's not exclusive, but it is the foundation. Now let me spend just a moment to tell you about desiccating stress. And desiccating stress is the result of MGD and a thin lipid layer. And really what is it? It's when the tear film cannot protect the ocular surface. And there are many causes: wind, dry air, computer use, the way we live, contact lenses, lid seal, etc. Blepharoplasty, of course, is a big one, as we all know. Now, everyone is exposed to desiccating stress, and we need this adequate tear film. And desiccating stress really impacts the corneal nerves, the nociceptors, the one that receive the stimulus, and their goal is to guard the cornea. So if they're constantly subjected to stress, what happens? They suffer from hyperalgesia. They become sensitized. So it takes less and less stimulus for them to it takes less and less stimulus for them to react. So the patient reports, I feel my eyes burn, my eyes sting. So desiccating stress impacts it in that way, and ultimately, as I said before, it leads to chronic upregulation of the lacrimal gland and the meibomian glands, which further wears them out. So I always think of a dry eye cascade, where we have obstruction, desiccating stress, decrease in lipid, evaporation increases, decrease in thickness, desiccating stress, and then you have a cascade. You reach a point where you have a cascade, and then you have the sequelae. And the sequelae are inflammation, dry eye, atrophy, and gland loss. And here we have what I call the stare test, which we did earlier. Normally, in a normal lecture, I'd stop here and have everybody stare to understand that. But that's what desiccating stress is. Then the next question is inflammation the cause or a sequelae of dry eye? And for many years, we all believed that inflammation caused the dry eye. And it probably does with certain rare immune diseases, which are 3 to 5% of all the dry eye. But for those of us who see so much dry eye, or have a dry eye center where we only see dry eye, it seems like it's 100%, because those are the people that we see. So we're seeing the 3 to 5% of these individuals. Now, what's very, very important, this is the key study that's been done. This is a landmark study, and there's a man named James Jester who has been involved in meibomian glands for 40 years. He's a PhD scientist, done some great, great work. And his graduate student, his fellow, proved that evaporative stress is the root cause of dry eye and loss of glands. So what happened is they placed mice in cages in a low humidity environment. That was step one. Then they had mice in lesser humidity, and finally in very low humidity, high humidity. So they had them in high humidity, medium humidity, and low humidity. And they created air circulation to make the stress even more. And what happened to these poor little mice? They increased their meibocyte production, went way, 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 way up. And they found out that they had morphological changes of structure and quality and the quality of the meibum. But what it did, it was so severe that it depleted the meibocyte stem cells. So once you deplete the meibocyte stem cells all over, you're not going to have anything. And what it actually did is it caused what they said was early aging, meibomian gland atrophy, and dropout. So when you looked at these individuals, at these mice, they had lost all their meibomian glands at an age that corresponds to about 5 years of a human's life. And that's exactly what happens to our students, because we put students into a high-speed college program or a medical school program, and within 5 years, we're now finding in study versus a control that that's what happens to them. They lose their glands. So this is just such an important paper. So Halem et al., 2014, coming out of Leicester's laboratory. And all of the meibomian glands were basically gone, corresponding to 5 years of human life. So I would propose to you, as provocative as it may be, that when you look at this and you say dry eye, you can only say that dry eye is truly the wrong diagnosis for millions. Because if there's 20 million individuals in the United States and 60% of them fall into that category, then every year there's 12 million wrong diagnoses where they're treated for tear deficiency. They're treated with artificial tears. They're treated with the tear film products that I invented. And it's palliative. It doesn't attack the root cause. Now, there's an exquisite model here. And the words, it's too bad that everyone in the room doesn't have a PhD in English. I certainly don't. But the words here are words that only a PhD in English could really understand and appreciate. But I'll try them. The universal inciting exogenous noxious stimulant. Boy, that's a mouthful. But it's true. There's never been a better description. That, Dr. Henríquez, was Perry Rosenthal. Okay. And it results in excessive evaporation. And you have corneal stimulation, like we've been talking about. You have an inflammatory cascade. You have osmotic stress, and you have pain. But these are parts of the cascade. When that happens, what do we have? We have visible and non-visible changes, tissue changes. So we see breakup time. Well, breakup time is a sequela. It's not the cause. Why do the tears break up? Because something's wrong. But in most of the instances, what's wrong is the meibomian glands don't provide adequate protection from evaporation. And then you have staining, goblet cells, lid wiper, liner marks, inflammation. Now on this side, this is Perry Rosenthal. And what he says is all of this causes corneal and nerve cell problems. And you get corneal hypersensitivity, which is hyperalgesia. But you can also go on to brain pain, central nervous system pain. And that's the condition where if somebody had a very severe condition of the legs and that required amputation, gangrene, and they were in constant pain, when you remove the leg, the pain should go away. But the pain may not go away, or only part of the pain may go away. And that's because the central nervous system has been inflamed for so long that it doesn't need a stimulus anymore to fire. It just fires. And in Boston now, in a laboratory, now there's 2 laboratories, they can actually show you when they rub a Q-tip across the cornea, the central nervous system, they can image it. They can image the nerves back in the brain. It's just incredulous to see what is happening. And on this side, there's tissue changes which are not obvious, But Pendram Hamra with confocal microscopy and immunology shows that there's a lot of fibrosis going on, and that fibrosis is the product of inflammation, long-term inflammation. And the Meibomian glands have fibrosis and severe inflammation. So most dry eye is the result of desiccating stress. There are many sequelae, including sensitivity of the corneal nerves, of the nociceptors. How do we treat it? Treat what? Treat the obstruction. And we also should, as I've said, treat the other primary coexisting factors. And the new goal of the treatment, a new goal should be what? We should think to prevent obstruction. That's the way we should think. If you want to test whether a person has central nervous system pain, if you put them in a goggle, and I'd be happy to send anybody who would write to me at drkorb@aol.com, if you put them into 100% humidity, within 20 minutes, they should have no ocular pain. If they have ocular pain, it's either because they have anatomical changes which are causing a problem, or it's because they have central nervous system pain, and it's usually central nervous system pain. And then the patient can understand their problem. So that's a test that should be done on anyone who has pain. So what you could do is you could put on a pair of goggles and chart the way they feel, the way your eyes feel. And within 20, certainly within 30 minutes, 99% of the discomfort should be alleviated, should go away. And we've published a number of times. Okay, well, where is MGD and desiccating stress going to lead us? It's going to lead us into a dental model. And if we look at the dental model, what happens? Well, food sticks to the mouth. If it isn't removed, you get plaque, you get infection, then you get bone loss, and you have all these problems. So it's a cascade that happens. You get caries, you get holes in your teeth, but ultimately you'll lose your teeth. And why? Because food and bacteria attack the gums and the teeth. What happens with dry eye? Well, the same thing that we gave. And when we get inflammation, dry eye atrophy, and gland loss. So the dental cascade and the dry eye cascade are exactly the same if you think in terms of Meibomian glands. And I've never met anybody, including myself, who really practices properly with the dental model. So where is it going to lead us to? We're going to stop tooth decay and gum disease. And they have what? When you go to the dentist to clean your teeth, does the dentist usually clean your teeth? No. There's an ocular hygienist. There's someone who's skilled at that one area. And I would predict that if I could come back and talk to you 10 years from now, and I would ask you and say, how many of you have an ocular hygienist in your office to do these things? You would raise your hand, because you would. Because if we treated these people properly, we would immediately double the number of visits to our office, and maybe triple them, because that's the kind of care that these people need. So we need annual or biannual exams. We have to check the Meibomian gland function with the instrument. We have to check the structure of the glands with meibography. We have to check their blinking. We have to check their lipid layer thickness. We should be debriding. Every ophthalmologist and optometrist should be debriding the lids at every visit. And we, of course, should do the questionnaire and the topography. And a lot of this, most of this is going to have to be done by technicians. So again, going back to where we started, why does the diagnosis of dry eye lead treatment astray? Well, it does because we think of inadequate tear production as the cause, and then we think of tear treatments. And we have to break that. We have to think of how do we treat the Meibomian glands, the key word being obstruction. And it diverts us from recognizing that lipid and not tears is the primary root cause. Yes, the condition is certainly dry eye, and we don't want to change the name, and we don't want to change the way we think about it. But the diagnosis is MGD. So you have dry eye. Dry eye is a sequelae of all these problems. And the diagnosis, 75% or more of the time, is NGD. And again, I just say that I believe that dry eye is the wrong diagnosis for me. So in summary, I would tell you that what I presented today is not the work of Donald Korb. Donald Korb has been blessed to be in the mecca of intellectual activity in the world. And Donald Korb has been very blessed to have met people such as Tony and many others, including you, with whom I've worked for many, 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 many years. And when I counted them out, I've worked with the #1 best chemist in the world. I've worked with 3 or 4 of the top 50 chemists in the world. And they have really been kind, and they really taught me. I work with Miguel Rafojo, one of the best chemists in the world. And so it's not me. I'm just able to observe and ask questions. And when you ask questions and you break the shackles of bondage intellectually that we're taught, and we look at the data, we really look at the data. Just because somebody gives you a pamphlet and says that omega-3s are going to solve all your problems. You know, I too would like the magic. I always wanted the magic pill. I wanted to be taller. I wanted to be better looking. I didn't want to be myopic. And I didn't want to be a blue-eyed Jew in a Christian society when I was a boy, because I was persecuted, as is natural. And I'm not complaining. It was good for me. But I wanted a pill to fix all that. And I never got the pill, because there is no pill to fix these things. It's just hard work. But you got to have the data. You really, really, really have to have the data of what these things do. And it's painful to get the data. And the very discouraging point about where we are, I mean, look how long it was before we knew. Every clinician knew that keeping the pressure was better than having the pressure go up. But nobody ever proved it until what? Within the past 10 years, when they did that big study in the United States. Then they proved it. I mean, but you got to have it. And then you need a second study to validate it. But there's no credit for people doing second studies. I was so happy after my 3 publications in Lid Wiper that the group in Turkey repeated it all. And they found virtually the same thing. I mean, they found a little different percent. They validated the work. So then if somebody validates your work, you can, or anyone's work, you can feel that it's good. So it's really been a pleasure to be with you tonight. It's really been unbelievably exciting for me, both emotionally and intellectually, to have spent the past 3 days with Dr. Henríquez just preparing this. And I really thank you for your attention. Thank you very much.